So anyway, I'm going to give a talk in San Antonio next week, and the talk in San Antonio was supposed to be before this talk, but they changed it on me, and so I'm giving you the talk first. It's going to be a little bit different because there I have a little bit more of time, but the reason that I don't want to this slides to go around is because I want people to feel that this is new material when I give the talk to them. That's the reason. Anyway, so why is subclinical TB important? And we're going to it. So basically, the pathogenesis of a base model of epidemiology of tuberculosis is you get exposed, and there are risk factors to exposure. You're in a developing country where there's a high incidence of TB, or you're in a congregate setting in the United States, in a prison, in a hospital. Then you get subclinical infection, which is basically latent tuberculosis infection and the risk factors for that. Then from latent tuberculosis infection, we know that most people do not progress to active disease, and actually only 10% do and 90% don't. So who are those that progress to active disease? There are some risk factors, but we do not completely understand why some people progress to active disease. And of those that are develop active disease, then we have infectious tuberculosis and non-infectious tuberculosis, meaning we cannot see the bacilli in the smear when we do the acid-fast bacilli. And there are risk factors as well after you get treatment for death and all of that. And in New Mexico, we have a high mortality rate that is mostly associated with the elderly and people that are diagnosed a little bit late. Or is not recognized the tuberculosis because it's not a typical presentation. So basically, the world that we live in TB is latent tuberculosis versus active disease. And many of you know this already, but we have the IGRA test in latent TB is positive, in active TB is mostly positive. In culture, the culture is negative for latent tuberculosis. That's the definition. You don't have active disease, so it should be negative. And in active disease, most of the time it is positive. The sputum smear in latent TB is negative, and active disease it might be positive or negative. Infectiousness, basically that you transmit to somebody else. In latent disease, is you're not active disease, you shouldn't transmit. And in active TB, you're at risk of transmitting to other symptoms. And this is where I'm going to be focusing a little bit here in this talk is with latent tuberculosis, none. And with active disease is mild to severe. And the preferred treatment you already know. So in most tuberculosis control programs, we focus in basically diagnosing and treating active disease, and latent tuberculosis infection is a priority in high-risk groups. And this is what we mostly do in the United States, but bear in mind that the focus of latent tuberculosis infection is not a priority in a lot of countries or developing countries in the world, and in some developed countries in Europe as well, that they have a priority. Their priority is mainly those that are contacts to active cases and immunocompromised, and that's it. So this is two studies looking at PET-CTs on the primate model, macaques. And basically what they do here is they infect them with by doing a bronchoscopy, they infect them with low dose of TB, and then they follow them. And in the left, by the study by Coleman, basically they are able to differentiate the macaques that develop latent tuberculosis infection and active TB. And what you can see here in active TB basically is like you see the uptake telling you that you have a lot of bacillary load there and a lot of bacilli. But in latent TB, you don't have a high bacillary load, but you have replicating M tuberculosis. So that dogma that we have that latent tuberculosis infection is basically the bacilli are not replicating and they're dormant is not true. What you do is a low level replication, but they're not really dormant per se. They're contained within a granuloma, and the immune system contains the disease, but it's not that the bacilli are dormant or not metabolically active. In the right, what you can see in the study of Nature Medicine 23, again in the macaque model, is after so many weeks of infection, what you can see is growth and then regress. So basically the TB regress. Here in this side here is the vessel, so it's very active. So it's not, that is not the disease. The disease is in the lung. Here it was not there here, and then it grows and it regrets. So it's basically the TB is in a flow. It's not static, and it's not moving forward from latent or semi-active to active disease. It can go back from in the spectrum. And here we can see on the bottom is the same thing, that it goes from active disease, from very little disease to basically consolidations, what we see in the lung of patients with active disease. So this spectrum of TB disease is very depicted here, and it is basically clinical disease that is latent tuberculosis infection, subclinical TB disease to active disease, and it can go back and forth. And so when it's LTBI, basically the definition is the culture should be negative, the smear should be negative, and the chest rate is normal. And of course, you have a test that tests you that you had been infected for tuberculosis, being the PPD or the skin test, or an IGRA. And asymptomatic disease of subclinically bacteriological negative incipient disease is usually latent tuberculosis infection that is likely to progress to subclinical TB or active disease, but you don't have radiological or microbiological evidence of disease, but you have a positive test, an IGRA or a skin test. An asymptomatic disease, that is the subclinical, what we're going to be talking a lot today, is subclinical that is bacteriologically positive disease, and chest rate that is also positive, but it could be minimal abnormalities. And I will discuss a case here today, two cases. But the key thing here is that they don't have any symptoms. When you ask them, do you have cough, fever, chills, weight loss, they tell you no. So, but they still have active disease. So how common is this? We're going to discuss it. So it goes also, and it could go back and forth to symptomatic clinical disease that is bacteriologically negative disease, basically, again, from positive to negative, or to positive, which is basically symptomatic, but then you have minimal abnormalities to extensive abnormalities when you have symptoms. So as you can see, there is a whole spectrum. So let's talk about the definition of subclinical TB. Bacteriological positive cultures. The person denies symptoms, usually responds no to a list of current symptoms. The symptoms, the symptoms usually in line with TB prevalence surveys, no cough or cough for a certain duration, and may have minimal or atypical radiological changes on chest X-ray. The problem with this definition is that symptoms are very subjective. So symptoms may be intermittent, mild, moderate, or severe. The respondents usually, it depends on how you ask the question, how persistent you are, and if you explain to them what the symptoms of tuberculosis are. And patients may not understand what you're asking. So that's, the lack of education about the disease. And also patients may not want to tell you that they have symptoms for different reasons, because they don't want to be discovered that they have an active disease, or for immigration purposes or things like that. So cultures may miss cases. And subclinical disease does not mean that the person is not infectious, or that the person is going to for sure progress to active disease. So incipient disease has been disputed since the early 1990s. So it's basically a symptomatic phase of disease with pathology that evolves to active disease. But it's usually the chest ray is negative and you don't have symptoms and the bacteriology is negative. But it is a disease basically that you are going to progress to active disease. We don't have any tests to test for this. Basically, this is LTBI that is going to progress to active disease, but there is a lot of research into this area trying to basically see if we can detect those patients that have latent disease that are at high risk for developing active disease, which they call incipient disease. So this is a little bit for research purposes, I would say. But for our clinical perspective, I don't think that it makes much of a difference for us to distinguish this from a latent disease. But one of the interesting things here is that we can assume incipient TB in some immunosuppressed persons. They have latent tuberculosis infection, but they are a transplant organ recipient and they're immunosuppression, so they're very likely to progress to active disease, or they have advanced HIV disease, or their own biologicals. So those people, you can assume that they have incipient disease. So, this kind of like a little bit screws up our TB4. So basically those patients that present with an abnormal chest ray compatible with TB, but that they don't have, a biological or a microbiological evidence of active disease. The important thing here is that, if you see a chest ray, for example, here with a right upper lobe infiltrate, you really, and a left upper lobe a little bit here too, you really need to get sputums and you really need to rule out disease. And the reason is that also, once you rule out disease, it is important to treat these people, because if you don't treat them, the risk of reactivating disease is much higher when they are microbiologically negative. Sometimes we go to the problem is that culture negative TB, and this is actually something that is very common here in the United States, not uncommon, I would say, is probably 10 to 15% of our cases any given year are culture negative TB. That is basically somebody like this kid that presents from Afghanistan with a lesion that looks like a cavitary lesion, no symptoms whatsoever, not losing weight, no fevers, no chills, but on chest X-ray, because he just emigrated, they did the chest X-ray and the skin test was, the IGA was positive, but the cultures are negative. So this is cultural TB, and a kid like this, most physicians will start him on treatment for cultural negative TB. We started him on treatment, and basically he did demonstrate some improvement on chest X-ray. He started closing that little cavity that he had there. So this met the definition of cultural negative TB basically. But this is not in that spectrum that I demonstrated there, but it's something that we encounter as clinicians trying to diagnose TB in the community. Another important definition to keep in mind for what I'm going to be talking a little bit later is what is passive case finding and active case finding. And this is the way that we diagnose TB, not only here in the United States, but in many other countries. So passive case finding is what basically most TB programs in the world do, which is wait for the persons or the patients that have symptoms to come to the medical care or to the hospital to seek help. And then, based on their symptoms, we say, this is like a TB, and we work them up and we find the disease, or we say you don't have TB. But active case finding is defined as a systematic screening for TB, including outside health facilities, and is more outside the health facilities, basically in the community at large, and maybe symptom-based agnostic. And what we mean by that is basically you might do x-rays or skin tests even if they don't have symptoms. And this is done in very high incidence countries, but in most places they do it based on symptoms. So they ask for symptoms, and then if they say symptoms that are compatible with TB, they give them chest X-rays, and they do cultures and other microbiological studies. So the advantage of this is that you detect diagnosis early and less advanced, and there are decreasing diagnostic delays. But it is very costly, because in order to find a case, you have to test a lot of people, and it's very costly. So that is one of the reasons that active case finding is not done even in high incidence countries a lot, because of the cost implicated by this. So the spectrum of tuberculosis disease, on the top is the classic conceptualization that I already spoke to you about, and the new conceptualization, which incorporates basically three elements that I have alluded to. So subclinical stages of disease from which transmission may occur without recognizable symptoms, basically subclinical disease, no symptoms. And there is regression and resolution to milder disease, possibly bidirectional, as I explained a little bit, and I will give an examples a little bit later, and the potential for diagnosis and treatment before recognizable symptoms, basically to treat, recognize them early and treat them. So you can go from uninfected to latent, go back, basically that you clear the disease and there is no evidence that you have had been infected with MTB or tuberculosis, or you go to incipient disease, what I described before, that is LTBI, but basically at high risk of becoming active disease, but you can also go back. And also you go to what we call subclinical disease, which basically there is not recognized symptoms, or subclinical disease with very little symptoms. And then to recognizable disease when patients are losing weight, they have a lot of cough, fever, and chills, and basically they come with a stamp in their forehead that say, I have tuberculosis, and these people may die, and a lot of these people will recognize them and we treat them. So this is the way to think about now about the spectrum of tuberculosis disease. So now I want to talk about the fatal and untreated pulmonary tuberculosis patients in the sanatorium. And this is an example from Switzerland in the 1930s, and this was published in the 1930s. So it's open tuberculosis and closed tuberculosis. So I want to ask the audience, so I don't know if Dr. Irlo, do you remember, or how do you hear what open tuberculosis or closed tuberculosis is?
No, 1930s, before my time.
Okay, yes. So actually, this is something that I heard from Michael Eisman like about 20 years ago. But basically, this is before the chemotherapy treatment. So open tuberculosis is when you're AFB smear positive. So, and closed tuberculosis is when you're smear negative. But the incredible thing, this is, again, this is before therapy. So it is that they follow these patients in the sanatorium, and if they were AFB smear positive, they tended to die quickly, like 50% within 2 years, and allow like 80% or close to 80% by 5 years. So they stay alive for a long time, even with tuberculosis. But the interesting thing is, compared to the AFB smear negative or closed tuberculosis, they basically survive for a very long time, 15 years or almost 20 years with tuberculosis, active tuberculosis, basically. And also, as you know, and many of you have heard that in the pre-chemotherapy era, not everybody died of tuberculosis. There were some patients that self-cured, basically that without chemotherapy, they didn't have TB anymore. And it was estimated to be about 30 to 50% of the cases. So we'll go into why is this important now, but long-term follow-up of tuberculosis sanatorium patients in the pre-chemotherapy shows the large difference between case fatality between sputum smear positive and sputum smear negative. So basically, if you were smear positive at that time, you have a high likelihood of dying quicker. And also, if you were smear negative, you were high likelihood of not dying as quick, and also having TB for a long time. So this is another study by Stivlo, and this is in a community of Czechoslovakia, and basically of about 100,000 people, and they did what we call now active case finding. So this is the first, or one of the first studies of active case finding. So basically they did x-rays and asked for symptoms and did sputums and cultures on almost everybody in the community that they were older than 15 years or 14 years of age. But what you see here is on the account of symptoms, basically only 66, or basically of 241, 25% of the patients were diagnosed on the account of symptoms, and 75% were diagnosed mostly by radiology, not on symptoms, mostly by the radiology in the community by doing case finding. So here, this is basically 75% in this study, we could say, that had or very mild symptoms or no symptoms, which is the definition what I say we have now of subclinical TB. And that is why I'm showing you this graph from 1960. And the other important stuff about this slide, I'm going to show it here, and these are bacillary pulmonary tuberculosis cases. It is that how many of them were diagnosed by culture and microscopy, but as you can see, they were treating the ones that they were finding, and as they started treating, in the follow-up that it was only like 4 or 5 years, they see a drop in the number of cases. So the active case finding in this population had a very positive impact, not only in less number of cases that they were diagnosing by year, but also in the terms of minimal, moderate to advanced disease on chest X-ray. So as years came by and they were doing more case finding, they were less severe on chest X-ray by cavitation and also other findings, and that is also important. But the most important thing here is that they demonstrated that active case finding in this community lowered the incidence of tuberculosis in females and males, and this is by year, by their age, sorry. And equally important, it was that the number of chronic excretors, this is people that basically most likely develop a resistance to the treatment at that time, also decreased. So there were less chronic excretors as they were doing case finding. So the burden of subclinical TB disease from prevalence surveys, and this is now important to what is a prevalence survey. So a prevalence survey is basically an area of a country or a country where you want to find out the prevalence of tuberculosis. This is different from case finding because case finding prevalence surveys is just one window in time. Active case finding, you do it for a period of some years to see if the disease decreases, basically, or as a strategy to try to decrease the incidence of tuberculosis. But the prevalence surveys is to find out how much TB you have in the community. And in these 28 prevalent population surveys, the median percentage of subclinical TB was 50%. This is in Africa and Asia. So what that means is that 50% of the patients that are presenting with tuberculosis don't have any symptoms. And I think that I think this, for me, this is interesting because I was not aware that, you know, subclinical disease was so common. And thinking back in my practice, actually, it makes sense. There are many cases in which they have very little symptoms to no symptoms, and many of them were found out by chest X-ray when they went to the hospital or through screening through immigration. So this is published by Francella in 2021. So on this same study, what it finds out is basically that radiology diagnoses 89 or confirmed 89% of the X-rays were bacteriologically confirmed. So basically, with radiology, you're detecting more tuberculosis suspects than by symptoms. So this is also important. So radiology, in a sense, is much more important to detect tuberculosis than just by symptoms. So this is 3 studies, and this is a meta-analysis of community-based active case-finding interventions. It was a review, and it was published in Lancet in 2021. But basically, what they found in these 3 studies is that case finding, when implemented with sufficient coverage and intensity, in high prevalence settings can possibly affect the community epidemiology of tuberculosis, which is something that I show you that Steve Lowe in what is it in Czechoslovakia demonstrated in the 1960s. And by the way, in the 1960s, they were already aware that success rate was extremely powerful. It was only in the 1970s and 80s in which symptoms became more important. And I think it was also a way of trying to reduce costs. So basically, you screen people first by symptoms, and then if they have positive symptoms, you do success rates and things like that. So it was more of an economical thing. But before, in the 60s and 50s, success rates, using success rates was very common. So this is another study in 2014 in which you say basically how much is tuberculosis screen worth and the economic impact of active case finding over 10 years. And this is modeling, but on actual data. And basically what you find is with active case finding in South Africa, the incidence, this is with the intervention, this is you're going to lower the incidence. In South Africa, the incidence is pretty much stable because about 20% of the population is infected with HIV. In China, which the incidence here, you see China, the incidence is much lower than in South Africa, is coming down, but with an intervention, it comes down much faster with active case finding. And in India, the same thing. If you do active case finding, you're going to lower the incidence of tuberculosis much more. And the importance of this is basically, if you do active case finding, you're going to be finding more of the subclinical disease and that you wouldn't find just by asking for symptoms. This is an important also study in the sense the effect of cultural in the screen algorithm of tuberculosis incidence in immigrants and refugees that are bound for the United States. So when they implemented culture in 2007, what they started seeing was a drop in the cumulative decline of tuberculosis in the United States by almost 2,500 cases. So the incidence of tuberculosis dropped significantly in the United States by screening immigrants by culture if they had an abnormal success rate and detecting active tuberculosis early before they immigrated to the United States and having them treated there, and then they were able to come to the United States. And this is still, now we do this and it's done in a much more systematic way. But when they started, it was in 2007, but it had an incredible success. And so much so that basically the incidence of tuberculosis among the foreign-born decreased substantially because we were diagnosing before a lot of cases that were in the first year of immigration to the United States, but it's basically people that had some clinical TB that we didn't know that was active disease. So, and this is a study also from about 11 countries. In which basically asymptomatic TB disease is typically lasts around 6 months. 6 months, the median of asymptomatic TB disease. And it could be anywhere from 4 to 14 months. And asymptomatic disease lasts even longer than symptomatic disease. So what this means is that asymptomatic disease or subclinical disease could be have a higher chance of transmission, even though they might be paucibacillary, because these people stay in that state for a longer period of time. That is when they have active symptoms, that is only about 2 to 3 months. So when you have subclinical disease, you can also generate aerosols with normal cough, or for example, people that have other respiratory illness. So you might have subclinical TB disease, but you have another respiratory illness, and then you start coughing and you have a higher chance of transmitting the disease. They have done studies on people with, without cough, and just with a mask, and they're able to find DNA of TB within the mask. So, and also there was a study by Comas, a group from Spain with whole genomic sequencing. I don't have time to go into this, but basically they show with whole genomic sequencing that people transmit tuberculosis before they are have active symptoms. So subclinical TB can transmit tuberculosis, and these are the references. So now I'm going to go to an interesting case. This is a 37-year-old male from Peru. He was detained by ICE, immigration services. He goes to the ICE facility and he doesn't have any symptoms, but anybody that goes to the ICE facility or prisons, most of them get a chest X-ray. So he gets a chest X-ray and you see the chest X-ray here. As you can tell, that the patient has bilateral infiltrates. He might have a cavity here and maybe a cavity here, maybe on the left upper lobe too. But I mean, this is something that used to say, oh, maybe this patient has active tuberculosis. So basically, the CT was done later. And you can see here the densities here, but as well as the cavity in the left upper lobe, but also a cavity in the right upper lobe. The interesting thing is that this patient didn't have any symptoms. So this patient didn't have symptoms, and he had what I would think it is extensive disease on his chest X-rays. The sputum, he was 4+, so he was acid fast bacilli positive, so he was very infectious. And gene expert, it was rifampin resistant. And we later found out that he is also INH and rifampin resistant. He's a multi-drug resistant TB case that was just picked up by X-ray. So this is a subclinical case. The patient denied any symptoms when we interviewed him, because for me it was a little bit surprising with that chest X-ray that he didn't have any symptoms. And actually, we started treatment on him, and we started treatment, and maybe in another occasion I talk about this. We started him with the new treatment for XDR. It's not really used for MDR, but in this circumstance, we thought that it was appropriate to use. And he's now on treatment. He's now on to 6 weeks of treatment. And again, I asked him, do you feel better? And he says, no, I feel the same. And his weight, he's gaining a little bit of weight, but I think it could be also because the food in the ICE facility was not as good. And now that he's out, the Department of Health is paying for the food, he's eating better. But then the question is, based on this case and the subclinical disease, is how much transmissible TB may subclinical TB generate? I mean, is this really the tip of the iceberg? Basically, that before we were not paying too much attention to these cases, and they're the ones that maybe are transmitting a lot or equally to the ones that are active and with a lot of symptoms. So the question is how much. We know bacillary forms are associated with transmission, and we know that I just show you a case that because you're subclinical, that doesn't mean that you're less diseased. It could be advanced disease as well. And so the interesting thing is that WHO did some reviews of different techniques to screen for tuberculosis, and they found different sensitivities. So for example, for cough, greater than 2 weeks, the sensitivity is only 40%, 0.4, sorry. Yeah, any cough, 0.5, any symptoms, 0.7, so better. Any symptoms is better than just cough or cough for greater than 2 weeks. And sorry, did you
cut yourself off, Marcos?
Huh?
I said, did you cut yourself off?
Did you cut me off?
Not me.
Okay, let's see.
Can you find it for your?
Can you see it now?
No,
not yet.
share screen again.
So sorry, guys. I think it was Diana.
Yeah, I know about where you were, I think. Okay, here, I think I got it up here.
I think, did I share?
Yeah, there it is.
Okay, yep, you got it.
Good.
Okay, so you got it? So, so let me go back a little bit. So anyway, the what the WHO is saying, what basically that symptoms, the sensitivity of symptoms is low, and the sensitivity of success rate is much higher. It's like 0.9. It's much higher. What I demonstrated to you with the steroid case from the 1960s, you know, success rate, the sensitivity is much higher, and molecular test is only about 0.69. So so for the main changes that the WHO guidance for screening for tuberculosis in 2021 is basically they're saying you should do community-wide system screening, which is active case finding. And you should use success rates, and they go a little bit farther. You can use computer-aided detection. So this is basically artificial intelligence to help you interpret the X-rays. And this is done now by companies over the internet. And they are saying that developing countries should be doing this because in developing countries, they don't have the manpower of the expertise sometimes to read these X-rays. So this would be a good way for them to do this. And molecular rapid tests we should be using it much widely. And C-reactive protein, which I was not aware of, you know, can also help you diagnose TB. And this C-reactive protein is as sensitive as symptoms. So if you have somebody that with C-reactive protein that fit the risk factors for TB and is greater than 5, this might be you know, somebody that might have active disease, and you will do the same that if they had symptoms. So this is what they're doing, especially in patients with HIV positive, looking for TB in you know, in Africa. And this is what the WHO is now advocating for. So in summary, subclinical TB, a large part of the prevalence of TB disease, follows a heterogeneous clinical trajectory, it can go back and forth, has meaningful infectious potential. We will miss clinical disease by using passive screening tools. We need to actively look for cases. Active case finding, a basic tool for TB control to detect clinical TB, and is now you know, sponsored by WHO, is something that we should be doing. And subclinical disease may account for a large fraction of TB transmission at the population level, but we need to quantify how much of it and how much turnover there is and how infectious it is. Thank you very much. Now I'm open for questions.
Thank you, Marcos. That was really interesting.
Yeah, thank you. It was interesting to me to put this talk together because I didn't know about many of these things.
Yeah, especially the fact that it can go back and forth between, you know, quote, latent to, yeah, subclinical. And so does anybody have any questions?